and a very warm welcome to everyone joining us for the very first edition of LE&RN's Fireside Chat series, Conversations in Lymphatic Breakthroughs. I'm Veronica Seneriz, Patient Services Director at the Lymphatic Education and Research Network, and I'm truly honored to be your host today. This conversation is especially close to my heart. We'll be talking about chronic venous insufficiency, CVI, and the increased risks it brings for developing lymphedema. As someone living with lymphedema myself, I know how difficult it is to find reliable information and the right care. In my work with LE&RN at the Resource Center, I also hear these same concerns echoed by so many patients and families. Whether you've been formally diagnosed or not, this space is for you. That's why today feels so meaningful. To help us navigate this important topic, we are deeply honored to welcome one of the world's foremost experts in lymphedema treatment, Dr. Stanley Rockson, the Allan and Tina Neill Professor of Lymphatic Research and Medicine at Stanford University School of Medicine. Thank you so much, Dr. Stanley Rockson, for joining us here this morning. We are so glad to have you for our first Fireside Chat session. And the topic today is chronic venous insufficiency, along with questions as they relate to lymphedema.
Of course.
Thank you so much again for being here. As the Patient Services Director, I have about 10 questions I'm going to ask you. And I will start without further ado on our first one, which is, for someone with both lymphedema and chronic venous insufficiency, which conditions should be treated first, or can they be managed together?
That's a great question. In essence, they can be managed together, and the treatment of lymphedema and chronic venous insufficiency has tremendous overlapping qualities. So treating one, in a sense, means treating the other. But there are a couple of, very special considerations when a patient has what we now call often phlebolymphedema. So phlebo is the Greek prefix that means vein, like phlebotomy or phlebitis. So phlebolymphedema is the specific form of lymphedema that occurs when the pressure in the veins is elevated. And that in turn creates back pressure on tissue fluid accumulation, which increases the workload of the lymphatics, whose job it is to clear that fluid. And consequently, lymphedema can develop when the lymphatics simply become overwhelmed by the job that they're being asked to do. So that's what we call phlebolymphedema. The reason it's important to make the distinction, one is in the form of diagnostics and one is in the form of therapeutics. Diagnostically speaking, there are certain conditions in which we can structurally treat the veins in order to reduce that workload on the lymphatics. And while that may not cure the lymphedema, it certainly will make the lymphedema much more amenable to any kind of treatment intervention that we are hoping to undertake. So very often, if a patient presents with a suggestion of phlebolymphedema, the very first test that should be done will be called a duplex venous study. So it is an ultrasound of the veins, but not looking necessarily for clots. We may be interested in that, in which case will be part of the examination. But generally speaking, in this patient population, we want to be doing an ultrasound evaluation of the veins in the legs in the upright position so that gravity is exerting its effect. And then we can see whether or not the flow direction is altered, the velocity of the flow, and basically to ascertain whether there are valves within the veins that are not functioning competently. Because in some of these situations, there are procedures that can be done to actually ablate veins that are carrying blood in the wrong direction and are overloading the lymphatics. And that, again, will not cure lymphedema, in almost any circumstance, but it certainly will mean that anything that we do to minimize edema will be much more effective once we stop the leak, if you want to think of it that way. The second examination that is often done if we are concerned about a problem in the venous system above the level of the hips, then we have to do some form of venography. In my institution, we do it typically with a CAT scan of the abdomen and pelvis, but in some institutions it will be done by MRI. There are pros and cons to both approaches, but basically we're looking for a structural defect that may be amenable to some form of intervention. So that's all on the diagnostic side. And of course, there's a therapeutic implication if we are going to undertake some kind of a procedure. On the therapeutic side, lymphedema patients are very familiar with the general rule that they are given that we should not use diuretics to treat lymphedema. And that's because the problem in lymphedema, purely stated, is protein accumulation in the tissues that pulls the fluid with it. Diuretics can only help the body to clear the water composition of the extra fluid, leaving the protein behind. And what we end up having is a kind of ebbing and flowing of the tides in and out of the tissues, which in the long run is not beneficial to the lymphedema. And that would be true for anybody who has lymphedema on the basis of obstruction, like a cancer survivor or somebody who's had a traumatic insult to the lymphatics or as a result of infection. But phlebolymphedema is the glaring exception to that, because in the case of phlebolymphedema, it is the excess fluid accumulation in the tissues that is the driving force. And we can actually make the venous component more competent by shrinking the blood volume a little bit with diuretics. And that is the one circumstance in which we will treat lymphedema with a low dose diuretic, understanding that more is not better. If the patient initially responds to a low dose and then seems to respond less, we don't keep incrementing the dose. We might do that in heart failure, but we don't do that for chronic edema. So that was a very long answer to say it happens together, but with some very important considerations if we're interested in the veins.
That's great. I really love that answer, and I learned a couple of things that I didn't know. How can a patient tell if their swelling is from lymphatic issues, venous issues, or both? That is to say, how can a patient know when to tell their doctor?
One would hope that the doctor doesn't need to be told, but in the event that it is the case that he or she needs a little prompting, there are some clues. It's not particularly easy for a patient to make this distinction. It's a bit of a challenge for the clinician who theoretically has years of training behind this decision making. But here are the things I would think about. In the earliest phases of lymphedema from any cause, the swelling of the limb will decrease with time overnight. So the patient goes to bed, let's say, with swollen ankles or swollen feet or swollen calves, and by morning, the legs look relatively normal.
That's a great
And
point.
that is, in the case of any form of lymphedema, what we call stage 1. That is, for most cases of lymphedema, a flow through, which is to say, in my experience, the majority of lymphedema patients go from stage 1 to stage 2 almost immediately, certainly within a matter of months. However, if there is a patient who notices that month after month, year after year, that's how the limbs behave. They get better overnight. They get better if the patient puts the legs up on the wall for 20 minutes or they lie down with the feet up on pillows. That may be a clue that there's a venous component, because that is the hallmark of the behavior of the central circulation with regard to fluid accumulation. The veins are very much affected in their work by gravity. So removing the effect of gravity allows that fluid to clear. So if it becomes evident that this is maybe not just stage 1 lymphedema, but that this is the chronic appearance and behavior of the limbs, I would question a venous component. The second big issue is, and this is a little harder to distinguish, but there is a physical finding that we call dependent rubor. Basically, that means when you're standing up, your legs are reddish. That's rubor means red in Latin. And dependent rubor is a sign of venous hypertension. So that when we see that, we again become curious about the veins. It's a little easier for an observer to see than the individual looking down at his or her own legs. It can also be confusing because in lymphedema, there is an increase in blood flow to the skin in general. So the legs may be a little reddish all of the time, and it may be harder to distinguish that increasing redness on standing. The third attribute is pigment deposition. Over time, when you have venous hypertension or elevated pressure in the veins from any cause, there is always a trickle of the blood outside of the veins into the tissues. Blood contains red blood cells, and red blood cells in turn contain iron. Once the red blood cells leak out of the capillaries or out of the veins, they don't go back again. So the body has to digest those red blood cells as they exist in the tissues. And the body can break down every component of the red blood cell but the iron that's in the hemoglobin. And the iron has a pigment. And so over time, it becomes like a little tattoo in the skin. And we call these hemosiderin deposits. So hemosiderin is the form of the iron in the hemoglobin that it takes after it's been partially digested by the body. So seeing that kind of pigment tattooing of the parts of the leg where the swelling occurs, that's another sign that there is venous hypertension and that there should be a further examination. And the final and maybe the easiest one to ascertain especially for women who I think spend more time looking at their legs than men do, is seeing varicose veins, which you mentioned at the beginning. And
Yes.
varicose veins are not the problem by themselves, but they are basically an attribute or a symptom of the venous hypertension. As the pressure in the veins goes up, that creates a back pressure that is a little bit like a garden hose springing leaks. And the leaks take the form of varicose veins, which become dilated and bulge out to the surface and are a superficial sign that there may be an underlying elevation in vein pressure.
What is the biggest misconception patients and even doctors have about these conditions?
Probably, I would say, when a lay person, for doctors, I think it's more lack of full awareness of how the circulation works and how the lymphatics in the veins have to cooperate with one another. On the patient side, it's more as we try to describe to a layperson what is happening in the circulation, there is this misconception that the failure of the valves in the veins to work properly means that there is blood leaking into the tissues. That's not the case. It simply is, maybe the best analogy I could use is if you think about a major highway that's in the middle of a rush hour traffic jam, the traffic slows to so much of a degree that eventually even the on-ramps become slowed and the cars simply have difficulty entering the highway. That's really what's happening in terms of this back leakage in the veins. There really isn't, the blood isn't exiting the vein except these stray red blood cells that I mentioned moments ago, but rather there's so much pressure in the system that everything is forced, in a sense, in the wrong direction. And I think that's a little hard for the layperson to conceptualize who doesn't have a really strong understanding of how the circulation is configured.
So here's a question that we often get. Many times patients are immediately suggested to wear compression. What happens when compression isn't enough? What's the next best step?
I'm afraid the person who's asking that question isn't going to like the answer, because once the workup has been done, if the workup is complete and everything that is reversible or correctable has been addressed, then if compression isn't enough, it means that we need more compression. There isn't an exit ramp for that one.
Gotcha.
We can fix what we can fix, but there are aspects of chronic vein disease that can't be fixed. So this is a good time to help the listener understand that in the human body, the venous system in the legs really it consists of a major highway, we call the deep venous system, and what you could think of as a kind of an access road, uh, which is the superficial system. When we do venous ultrasounds or other imaging tests to look for some correctable factors, we're looking for problems in the access road, because the access road can be addressed through procedures. Varicose veins can be removed or can be intervened upon in ways that reduce their impact. But the deep system cannot be intervened upon at this point in medical history. There are many individuals and companies working on solutions for this, but they're not ready for prime time yet. So basically, what I'm saying is, if a patient has had an evaluation and there is no superficial reflux um, to be corrected, and all of the problems are in the deep system, then unfortunately, low dose diuretics and compression are really the full universe of what we have to offer. And if less compression doesn't work, then we need more compression. And it's all to prevent the complications and the progression of the disease if we don't halt its forward progress in terms of edema and the damage that the edema does to the tissues.
Well, I, as a patient with both CVI and lymphedema, appreciate that candor. Often as patients, we wonder, am I doing enough? Have I exhausted all options? And having that explanation goes a long way.
Right.
Um,
If I can add one other thing, because this is going to be on the other side of the coin, I think there is a problem in this realm, which is to say that the number of people in the world that have abnormal ultrasounds of the veins is far greater than the number of people who have phlebolymphedema or who have isolated venous hypertension. And I think it becomes very easy out in the world to do these studies and equate any finding on those studies with the need to do something. And sometimes the doing something actually leaves the patient in a worse situation than prior to the examination. So I think it's important to be aggressively interested in correctable entities, but not to overtreat anatomy. Anatomy has to be looked at in the context of function, understanding the entire behavior of the circulation to determine whether an ablation or some form of intervention is actually going to help the patient.
It's a great answer, or great addition to your original answer.
Sure, thank you.
Are there daily routines or habits that can significantly improve both conditions?
Um, I would say that, of course, we talked about compression, so being compliant with the compression is probably at the core of the answer to what you're asking. The corollary of the role of diuretics in phlebolymphedema, not in obstructive lymphedema, is that in settings in which we would anticipate that a diuretic might help, it will also, of course, help to not overconsume sodium, because diuretics work by changing the way in which the body clears sodium so that the fluid goes with it. So it's in the same way that we don't say, take a dose of a statin so that you can, eat your steak. We don't say, take a diuretic so that you can put, gobs of salt on your popcorn or what have you. So paying attention to sodium is important. And to a degree, it is for obstructive lymphedema as well, in the sense that overconsumption of sodium will cause swelling to occur generally in the body. So any realm of the body that's already exposed to a pathological degree of edema is going to become that much more edematous. It isn't that the salt goes directly to the lymphedema limb, but the lymphedema limb will bear the consequences of what's happening throughout the body. The next point I'd like to make is that there are supplements that we sometimes prescribe to individuals who have venous hypertension in particular, that are have a wonderful role in making the tissues more resilient to the edema, reducing the inflammation that occurs with the edema, and to a degree improving vein function itself. And these are plant-based compounds that are very generally safe. They're really not a downside. Some of them are already present in some degrees in the diet. Others are not necessarily dietarily derived, but provide benefit. And there's a long track record of scientific investigation of these compounds. So one broad category are the bioflavonoids that are present particularly in citrus fruits and in other foods. There is a compound that is extracted from the seed of the horse chestnut tree that also has a more than 100-year history in being used in venous medicine. And grapeseed extract is another one that is known to improve these general conditions. So those aren't necessarily general guidelines to follow in daily life, but for somebody who is suffering particularly symptomatically from the venous component of the presentation, heaviness of the limbs, and aching from the varicose veins and other things, these compounds can help.
Well, I certainly will rewatch this recording and take notes. So I'm
Yeah,
not
great.
taking notes now. These are very powerful tips and suggestions,
Sure.
at least to me personally. Um, Now that you've touched a bit about dietary suggestions, how important is exercise, and are there specific movements that are most effective?
Yes, so exercise is, I would say, extremely important, but it's very important for the chronic edema patient to understand that exercise can be either beneficial or detrimental in the way in which it is being applied. So here's what I mean by that.
Okay.
If we're dealing with an intact circulation, the veins are under normal pressure, the lymphatics work normally, then any form of exercise of the limb that we're looking at will improve fluid clearance from the limb, because in the case of the lymphatics specifically, there's what we call the extrinsic pump, which means that when the muscles contract around the lymphatics, they actually help the lymphatics to more effectively propel the fluid back to the heart. And there's a similar function, particularly in the calf, when it comes to venous function. The problem is that if you deal with somebody whose circulation is not working at 100%, the other variable that we need to consider is that as you exercise, blood flow to that limb increases proportionately. And the amount of fluid that ends up in the tissues from the action of the circulation is proportional to the total amount of blood going through there. So if you exercise and you have a defective circulation and are not compressing the limb, then the increased tissue fluid formation may overwhelm the beneficial effect of the exercise on the clearance of fluid. So the simple answer is exercise is universally helpful if compression is in place when the patient has edema to begin with. The other point I want to make about venous disease specifically, not thinking so much about the lymphatic component, is again to pay attention to this calf muscle pump. It is a very important way in which venous function can be augmented. So even a couch potato can benefit from doing passive calf raises. Basically, an individual sits on a chair or the couch with the feet flat on the floor and simply doing passive heel raises by keeping the toes in contact with the floor and simply allowing the heel to go up and down will activate that calf muscle pump and will help to clear fluid based upon venous pressure. So doing a minute of those 2, 3, 4 times a day, even if nothing else is done, is going to help the overall situation.
I also do that when I'm flying.
Excellent.
Pumps while flying.
Yeah, yeah. That there are two purposes there. One is that it, of course, it helps to prevent edema, but in the case of air travel, there is the ever-present low-grade threat of clots, and keeping everything flowing in a very orderly way is the best way to prevent DVT related to air travel.
I'm going to switch gears with this next question on more of the clinical side. What breakthrough in research gives you the most hope right now?
Well, I have to be, well, I'm going to mention two things. One of them I have to confess is very self-serving. I'm very excited by the moves forward that we've made in imaging. Venous imaging is not a problem. We can do it non-invasively. We can do it semi-invasively. We can learn a lot about the veins, but the lymphatics, as we all know, are like the invisible mortar in a brick wall. You know, it's critical, but it's very hard to see. And we have traditionally had a great deal of difficulty in imaging the lymphatics and knowing what's wrong. But the moves forward that we've made specifically with MRI and contrast-enhanced MRI for lymphatics is tremendous. And then for all of the audience who has been evaluated for or gone through any form of lymphatic surgery, the ICG lymphography that we're now able to do to look at the superficial lymphatics and understand their structure and their structural defects is really wonderful. And I'm very excited by the fact that I think we're moving into an era where we're not going to just be limited to a qualitative description of what things look like, but that we'll actually be able to use the ICG imaging to say quantifiable, factual deliberations about the lymphatics. I'm also very excited, I have to admit, with the progress that we're making with drug therapy for lymphedema, and now most recently for lipedema, which is really aside from today's discussion, but we're quite excited by the fact that we're just concluding our phase 2 clinical trial of a drug for lymphedema. And I have to admit, I've been on the trail of this drug, you know, for coming on 30 years now. So to see it so close and to see how dramatically the patients are responding is really gratifying. And I hope that we will enter a new era in which, among other things, we can treat lymphatic and venous disease like we treat the majority of adult human diseases, which is a prescription, go to the corner drugstore and take as prescribed and get better, you know, so that we'll hope that's eventually going to happen.
Well, I have to say I'm a little bit self-serving as well. I mean, as a patient for 31 years, you know, my journey is been in parallel with
Yep.
your research career. So
Yes,
I hope in my lifetime
yeah, yep, you and I
we
started
will
at the
see
same time from opposite sides.
So, thank you for sharing that. And
Sure.
I'm sure the audience will appreciate all of those developments. Is there any, well, we just covered that. That was my number 8 question. Are there any medications? And you just covered that.
Well,
Um,
so we talked about the supplements, which I think are, of course, very important, certainly in lymphatic-venous medicine. I also have to mention that there is a subgroup of patients that come under this category who have Phlebolymphedema on the basis of prior DVT. And there is a very common form of this that has a slightly different name. It's called post-phlebitic syndrome, in which the limb becomes chronically swollen in the aftermath of a DVT that's already been completed. And it is for one of two reasons. Sometimes the clot material doesn't clear completely through the body's ability to dissolve it. And sometimes the damage to the vein is insurmountable, even though the clot eventually goes away. But patients who've had major DVT are candidates for chronic anticoagulation because the recurrence rate of
okay.
DVT once a single one has occurred is really extraordinarily high. So I have to mention anticoagulants in this context as well. And fortunately, in this era, modern era, we have a category of compounds called the direct thrombin inhibitors, which have taken away most of the pain of taking a chronic anticoagulant in the generation in which I went to medical school and for 30 years thereafter. We had to use a drug called warfarin, which was very effective, but requires constant blood monitoring, constant adjustment of dosing, and really kind of a pain to be a warfarin recipient. But now that the majority of these patients can take the direct thrombin inhibitors, it's a once or twice a day medication. It's not doesn't have to be weight or size adjusted. It doesn't have to be monitored through chronic testing. So it's really a big advance, but critical for that subgroup of patients who fall into that category.
That was a great ad because we do have a lot of, well, I have seen anecdotally patients share when they've had DVT, even as lymphedema patients. So
Exactly.
it's great. What is one early sign of trouble that patients should never ignore?
Oh, that's a difficult question. I think I'm going to change the emphasis a little bit, which is to say um, the earliest stage of chronic edema is already a fairly advanced pathology. By that I mean chronic edema invokes inflammatory changes in the tissues almost immediately. And what we know from my 30 plus years of research is that early inflammatory response in turn causes pretty substantial architectural changes in the tissues, many of which have been historically not reversible, although I'm happy to say drug therapy does cause reversal now we see, but they become very established. So what I want to say is that early tendencies toward chronic edema should not be ignored, even though they seem relatively trivial. Get these things evaluated, find out what is the cause, which compartment of the circulation is affected. We haven't talked about the fact that there's another piece of all of this, and I have to say this as a cardiologist. One of the important causes of venous hypertension is heart disease, because whatever the pressure is in the legs that's causing edema in the legs may be an expression of what the pressure is as the blood enters the heart. That may be the point at which it's elevated. So almost always patients like this are going to need some non-invasive evaluation of cardiac function as well. A big subset of the patients that I see with chronic Phlebolymphedema have sleep apnea. And sleep apnea, so that's even beyond the heart, that's the lungs, right? So the lungs are dysfunctional in the ways that they are during sleep. That raises the pressure on the right side of the heart as it tries to bring the blood into the lungs. And that elevated pressure in the right side of the heart gets communicated all the way back down to the ankles. So there are a lot of clues that are nested in this presentation of early chronic edema. And it shouldn't be waiting until the skin breaks down or until you can't fit your foot into your shoe anymore. We'd really rather intervene at a much earlier time point.
I've had so many aha moments
Oh, good.
with you today.
Well,
My last question is, what's one thing every patient could start doing today to protect their lymphatic and venous health?
I would say when it comes to lymphatic health, it's really about living a sane and healthy life. So there aren't very many specific recommendations. I think following a healthy diet that is not too calorically overloaded, that is as free as possible of ultra processed foods, not overly uh, endowed with too much sodium for the reasons we talked about before. I think having a consistent and healthy sleep cycle is very important. The human body really does require a consistent time of going to bed and awakening and a sufficient number of hours of sleep that will in turn ensure that there's enough deep sleep and REM sleep. And we now know that the lymphatics in the brain, which are responsible for clearing all the junk out of our brains, are most functional during sleep. So that would be very relevant, not to swollen legs, but to the lymphatic system as we understand it. When it comes to venous disease, I think a lot of the same issues apply. I think some attention should be paid to body weight and idealizing body weight, and thereby, thinking about nutritional components that might lead to weight gain. I think we've talked about why regular exercise is important, and if nothing else, doing those calf raises. If you're not going to get up and walk around, uh, do that. I think a daily walking regimen is good for mind and body, and getting outside is even better than doing it on a treadmill. So another way of saying it is the circulation will be healthy if the body is healthy. And doing everything we can to help the body be healthy is the best way to have a healthy circulation.
Thank you so much. As I said
Thank you.
before, it's an honor and privilege to be able to interview you as the first in our inaugural Fire Chat session series. I personally learned so much, and I'm sure the audience watching today not only has learned a lot, but will have many fired up questions to follow. So again, thank you for your time. We appreciate all you do on behalf of the entire world and our patient community. And I'm looking forward to hearing more about the recent developments from your accomplishments from research.
Thank you so much. Thank you.